So any thoughts about this lady? So she came to see me. This is the lady I was telling you about. And I showed her some numbers and she couldn't decide. She went home and talked about it with her daughter. And she asked me, and I said, if I was you, I'd take the medication. Because the risk's up there. She's up in that on my original graph. What would you do with her? Okay, so 2 weeks. So her blood pressure, so on hydrochlorothiazide, half a tablet, her blood pressure went down to 138/70. The reason I gave that rather than losartan was because she'd been on it before and hadn't had any problems. But as I said before, I find about 20% of people get cough on ACE. So when I had this light bulb moment that I could give ARBs, and essentially there was a question before from Angela about whether they're equivalent, and I think, as far from my reading, is essentially whenever they've been studied, they had the same outcomes as ACEs. But your question was about post-MI, and I don't know about post-MI.
There's not nearly as much data, but I think they're probably equivalent.
Yeah.
We tend to use ACEs because there's more data on ACEs.
Yeah.
I mean, it's quite a big. I mean, you'd have to say that's a pretty impressive benefit from one combination tablet. Probably there's a little bit of regression to the mean. But nevertheless, it's clearly, she's a lot lower cardiovascular risk with a blood pressure 138 than 165, and if simple treatment, well tolerated.
Yeah,
that's
actually it came down even further. It was another reading was 125. I find I get massive drops with that combination, which is why I start with a low dose. I gave her a half tablet. BMI is reasonable, so she wasn't, a skinny little old lady who's going to fall over.
That's one of the questions. I mean, there is some data that looks at getting a better benefit from combination and modest doses of 2 or 3 medications than a big dose of 1, and probably less side effects too.
Yeah, there was a randomised trial done, I think, in the George Institute where they gave 4 low dose. The modern thing is to give multiple low-dose medications because the biggest bang for the buck is in the first dose. With a lot of medications, so multiple low-dose medications is probably better than going to a high dose of 1, particularly the calcium channel blockers, because I find the ankle swelling is very dose-related. I never see it on 2.5 of flodipine, but once you're to 10, just about everybody seems to eventually get ankle swelling. And it doesn't necessarily turn up next week either. It can turn up a long time later.
So the advantage with her, that 82-year-old, that she will trust you until she hasn't gone onto Dr. Google.
I don't think she'd get onto Dr. Google. She's pretty old-fashioned. Grew up in Kenya and sort of colonial sort of style. I think she trusts me. So yeah, I'm very fond of this lady actually. And so when she asked me, boy, the last thing I want you is having a stroke when you're 85, and me not having given you the medication. I mean, part of it's my own anxiety coming out. But this was my mother. This is what I'd want. Do you want your mum having a stroke at 85? No, thank you. So the question now is, do I give her a full tablet?
Well, according to the SPRINT study, you probably should, as long as it's well tolerated.
Well,
but you've actually got haven't you got a full tablet there?
No, half a tablet.
Half a tablet chlorothiazide.
So what's the standing blood pressure?
Sorry?
What's the standing blood pressure?
Didn't check her standing blood pressure, but that's probably quite a good thing with older people. Some people suggest, I don't know what the evidence is for that, but just you may find, but she wasn't lightheaded when she was walking around, wasn't complaining of things. But yeah, some people would suggest we should with older people.
Is the risk of fall is high? If you increase to 1 now?
Sorry?
If you increase to full tablet, there's the risk of fall is high.
Well, yeah, but there's also a cardiovascular gain, so it's a bit of a balance, isn't it? So we've got rid of most of the risk. Now, so the numbers needed to treat are probably 10 to get an extra benefit versus the risk she may get over 10 years. A 10-year risk over 10 years. Numbers needed to treat is about 10. And that's very hard to explain to somebody. You can't explain numbers needed to treat to patients. We've tried doing that. We've done some research on it. I could show her the percentages, and this is what you'd get. She might again just ask me my opinion, and that would be tricky at that point. I might say to her, well, you can avoid extra harm will mean taking the full pill, which would be easier than taking half the pill, of course, and you may get some more side effects.
What's your cut-off age now? She's 92. What do you do?
Well, if she was in the shape she's in, I went to Antarctica with a 92-year-old. You know, this lady was, well, she was on somebody's arm because we didn't want her to fall over and break her hip and have to be, and the ship turn around and go back. But yeah, it depends how active people are. 92, you know, if she's in a rest home, I wouldn't go near her. You know.
So the interesting thing is, if she's 82 and she's in good shape, she probably has at least a 10-year life expectancy, probably.
Yeah.
Would you be worried about reduced organ perfusion if you went any lower with BP?
If you went to what?
Went any lower? Like
What organ are you worried about?
I don't know, they just all their organs have less blood flow, like your brain, if you're worried about
Yeah,
dementia.
I guess the other thing is high pressure also damages the brain, doesn't it?
I mean, I think the answer to those sort of questions is that's a theoretical concern, but the trials, that's why you need the trials. And the trials show that if you do that, the outcomes are better. And I think that actually, that's pretty important, because otherwise you can see the falls risk wasn't, we were all concerned of going to fall over, but actually when you do it in the trial, fewer falls. So the benefit of looking at that evidence is that it overcomes kind of, we tend to get prejudices because you think, oh, well, this is going to happen, then that's going to happen, then that must be bad. But we don't see you don't sort of see the benefits of the treatment in terms of, oh, a stroke happened, how do you know that was you can't directly link it to the treatment or not the treatment.
Going the other way with these older people, if you were de-prescribing, these are the last drugs I would stop on people. You know, the warfarin, dabigatran would be the very last one I would stop. If you're going to stop anything, these ones are getting benefits from. You think of all the garbage people are on when they're older. These are the last, these things you shouldn't probably stop, I don't think, because they'll be getting benefit, unless they're bed-bound or, they're frail and in an institution. But you have to look at the issues of frailty, and I think it's very telling. Actually, I want to write an editorial on that, just looking at the frailty, because I think we've got it wrong. I think we've got the frailty thing wrong when you see the numbers there. They're actually the frail people, the ones with the highest CVD risk. And we're all, I'm not a big prescriber. If we were talking antidepressants or antibiotics, I'd say keep the gun in the holster, guys. But when it comes to this stuff, bring it out when there's a good target. And I think this is definitely a good target. The issue, it's a bit more nuanced going from 138. That would be a difficult, you could say, well, there is an increased benefit. It's not massive, but it's, 1 in 10 people may get a benefit out of this. Do you want to take a whole pill? How would you feel about that? And I think that's getting her values out, because too often we get our values mixed up in all this.
So how low you want to go for this patient?
Well, in the sprint trial, they went down to 123. That's not a magic number, but 138, you're pretty close to 140. So she's is higher than the control group in the sprint trial. Okay, so that's interesting. So the next one is sort of getting into the really difficult one. And this is a lady, interestingly, she's doesn't like medication, and she doesn't like men. And I said, well, I'm a male doctor. She said, well, you're different. So she says, I don't like men. Okay, like, what am I doing here? Anyway, she's a slightly alternative lady. And interesting, she's just developed breast cancer, but her diabetes is out of control. She may have had an MI 20 years ago. She had chest pain, went into hospital. She had a very stressful time in life, and she actually had an enzyme rise. But when they did a catheter study, her arteries were completely clear. So there's that sort of history. And her blood pressure is 180 on 92. She was on insulin for a while, but she doesn't like it. She doesn't like metformin, which is why she's on a homeopathic dose. We're trying to get her back up. She's on all this medication, and her blood pressure is still 180 on 92. I don't know she's exercising regularly. She's just developed breast cancer, interestingly. BMI 33.6, and she still smokes. So she's a pretty high risk. She's going to be right up there with, we could do her risk, but it would be pretty high. So any thoughts about what you might want to do with this lady?
My first thought was she says she likes you, but...
I'm putting her blood pressure up. Okay.
She is on 4 blood pressure medications and her blood pressure is still 180. And I would be suspicious that she's not taken 4 blood pressure medication. And I look at her heart rate, you haven't got the heart rate, but if she's on 190 of metoprolol, that's a big dose of metoprolol. Her heart rate should be about 55 or 60, you know, so that would be my first thought, that maybe she's not taking the medications, because I think once you get to 4, and but if she was taking medications,
she does take from time to time, and I haven't got her lipids there, but she's not she was on atorvastatin for a while, and she took that sometimes. So, of course, the nice thing about statins is you can tell when people are taking them, and you can tell when they stop.
Yeah.
Your phone.
Well, it's interesting actually that if she's had a coronary angiogram and that was clear, and that actually is quite good evidence that she probably has a low risk of atherosclerotic disease, and maybe, it's not saying there's no benefit from statin, but maybe the benefit is somewhat less.
Smaller. Yeah, that was 20 years ago, mind you.
20 years ago, okay.
Yeah, so who knows what. She's had this poorly controlled diabetes.
Yeah, okay, fair enough, yeah.
Well, I'll tell you what we did with her. So she had a little bit of hirsutism on her face, and I thought, I'll give you a bit of spironolactone. She came into the office, she's on the spironolactone, and I had my little blood pressure machine. Her blood pressure was 120/80. We both looked at this machine and gasped, you know. But the problem I find with young people in spironolactone is they don't like it, women or men. I do have one man who's now 80 who likes the breast enlargement because he actually is transgender. But he's happily married. He and his wife go shopping in a different suburb. They both go out as women and they go shopping. But he's the only one who really likes spironolactone. The men don't like it because of the breast pain or the gynecomastia. There is a case control study showing GI side effects are more common. There's some risk of actually ulcers. I mean, BMJ actually, somebody went to the trouble of doing a case control study about GI side effects of spironolactone because of the GI, there was some thought about GI bleeding. And people just don't like it. I can't keep people on. The very elderly seem to tolerate it, but I think because life's so uncomfortable for them, they probably just don't notice. So that was one option, so that worked. Interesting, her serum renin was high. I don't normally do serum renins on people. I don't know whether that means anything. It's the only time I've ever done a renin on a patient, but I did wonder whether, it was blocking the... Anyway, so then I put her on clothalidone in spite of her asteroid, and her blood pressure came down to 120/80, but she didn't like that either. So I'm sort of sitting on this lady, and it's a good point whether she's actually taking them. I think she takes them sometimes, but she's pretty resistant to... but I mean, the other thing is, I thought she would have dropped, Deidre had a stroke 10 years ago, and she's still going. I just had a lady die recently, 85, who I fussed about her blood pressure and her diabetes, and she actually died of cancer in the end. I think all that fluffing around and fussing about your blood pressure and diabetes, and didn't do. Maybe we had it well controlled, but so you do wonder. People are feeling.
I guess the other thing is when whether she's got to what degree is white coat hypertension if she doesn't like doctors and she knows she's going to come along and be told about things she doesn't like.
Yes, it'd be good to get her to take a machine home actually and see what she's like. What she's like at home, that would be probably quite good with her. Sorry?
I can think about in the emergency department, a patient will come in, something simple, toothache, been awake all night, their blood pressure is horrible, but you'll give them some pain relief, maybe some injection, their blood pressure is still coming down, it's still high. But in that previous case, on either of those occasions, that patient's blood pressure might have been higher than it would normally because they come to the GP or they just missed the bus or something like that.
We'll just take a story.
Of course, always the problem is somebody sits there and their blood pressure goes 160, 150, 140, or 150, 140, 135, and it's always, that's probably where... Do you want to say anything about 24-hour blood pressure monitoring as a way around that? Or?
Well, I think that it's incredibly useful, actually. I mean, I think, well, certainly I find that my office blood pressure are completely unreliable, and the situation I most often see now is, for some reason, the immigration, so they're up for immigration, So they go along to their medical for the immigration. They're perfectly well. Their blood pressure is 170. So they immediately sent to the cardiologist, who then they're even more stressed, and their blood pressure is 180. But actually you do a 24-hour blood pressure and it's normal. So that provides objective evidence that it's normal as well. So, but obviously that's an extreme situation. But I suspect it happens quite a lot. Having said that, variation in blood pressure is actually a predictor of risk as well. So it's not that if you have high measurements, even though they are, other times they're low, it doesn't mean you have this same risk as being low all the time. In fact, and office blood pressure measurements do predict events. I mean, that's where the data came from the office measurements. So it's not entirely, you can't entirely discount it. And we shouldn't go for the lowest measurement. We tend to say, oh, well, I've got one measurement that's low, therefore you're okay, because we do know that the higher measurements do matter.
It's one reason why I like the electronic blood pressure machines. A, it gives me time to do things. I can be typing stuff up. But B, it's much more consistent. I get somebody with like 150, 90, 150, 90, and then they see somebody and they get like 110, 80. And I sort of look and think, well, did somebody get it wrong on that day, listening with their ears rather than with the machine? I think the one side of the machines, you do get goofy results on machines, but they're usually pretty obvious. But at least you get you do get a consistent. You're not going to have a bad day and not hearing. I had an interesting experience myself. I have hypertension. I went to see Ted Clark, who was my beloved cardiologist teacher when I was a house surgeon, and my blood pressure was perfectly normal in the office. He said, "You haven't got blood pressure." Okay. They did a 24-hour, and it was up, which was the opposite sort of problem. And I think it was being with a trusted colleague that my blood pressure was. I call it the blue, because he used to wear blue shirts. I call it the blue coat effect of Ted Clark. So if you really trust your clinician,
it shows that you're probably stressed all the rest of the time.
Yeah, that's right. Yeah, in his office, no deadlines, no ethics committee, no nothing. So what about?
Well, I mean, we do it we have the monitors that they're just a monitor that has a recording box in the box. But actually, I